Hello friends and welcome back to Perspectives Pharmacology. Today we are going to study a very important topic, that is Fishman 6th edition. And what's new, that is what are the changes from the previous 5th edition. It's a very lengthy topic, so I'll be dividing into part 1, part 2 and part 3. So today is the part 1. Before going it there, we'll study what are the major changes made. That total number of chapters in Fishman 6th edition is 152. In 5th edition there are 153. So what are the newer chapters added? This COPD with alpha antitrypsin deficiency, which is a newer chapter now. In the previous edition it was a combined chapter, and lung injury associated with recreational drug use, and uncommon tumors of the lung microbiome, and ECMO in respiratory failure. So these are the new chapters. In part 1, today we'll be studying what are the changes made from the chapter 1 to chapter number 34. Coming to directly chapter number 6, because chapter number 1 to 5 has no major changes. Chapter number 6, that is mucociliary clearance. This a figure, a very important image has been added, which shows the comparison between the normal airway, cystic fibrosis airway, and the primary ciliary dyskinesia airway. So you can see the normal airway, there is no mucus plugging up, because even the cilia is working and the sodium chloride pump is working. Okay. Cystic fibrosis, as you I all know, sodium chloride pump is disrupted, so the mucus gets thickened because of the hyperviscosity. You can see the primary ciliary dyskinesia syndrome. So even the sodium chloride channel is absolutely working, but the cilia is not working. Even in that cases, the mucus keeps on plugging up. This is the figure explaining the comparison between these three. Next here you can see the next table. The next table, important table, they added in the same chapter. They have shown the genes linked with the motile ciliopathy and the ultra structural findings. Okay, you can see this is the cilia, ultra structural finding, and the gene associated the normal structure. ODA is outer dynamin arm defect. What are the gene involved? IDA is the inner dynamin arm effect, defect, and what are the genes involved? Okay, go to this table, a very important. Third important change that they have made it in the same, that is the same, the mucociliary clearance chapter, is idiopathic bronchitis. They have defined it as a morphological term that describes irreversibly dilated bronchi in the absence of monogenic airway disease, in the absence of like cystic fibrosis and PCD, that is primary ciliary dyskinesia syndrome. Third important change in the same chapter. And fourth important change in the same chapter is autophagy. They added it in a treatment part. That is what they decided is hyperproduced mucins can be degraded intracellularly rather than being secreted. So how do it? By giving the patient mTOR inhibitor, that is sirolimus. This drug have been used for Lyme disease, not yet been used for this particular disease. It's still in the research pipeline. Okay, what they are doing? You use mTOR inhibitors to do autophagy of the mucins within the cell. A drug name is sirolimus. Okay. Coming to the chapter number 8, that is stem cell and respiratory disease. Here they have added a figure which is showing the epithelial cells along with the progenitor cells and what they can become in the future. Okay, you can see here clearly the trachea and bronchi, distal airway junction, and the alveolus. Okay, go to the figure. Coming to the 7, that is the 7th chapter, that is genetic basis of the respiratory disease. This is a table mainly how to report a variant. Suppose a cystic fibrosis patient, how to exactly report it. There is a chapter, there is a table significance. Coming to the next chapter, that is sleep and the circadian rhythm. Sorry, sleep and circadian rhythm. This is the figure added in the sleep and circadian rhythm, which was not there in the previous chapter, the previous edition. As you can see, the upper, if a circle, if you divide into two, upper hemicycle, which is orange one, it is showing what are the changes in the active learning and the wake cycle, and what are the changes during the sleep. Mainly your DNA repair, how the DNA repair occurs in and sleep cycle. And go through this figure. Next chapter, coming to the pulmonary circulation, they have added a very important definition. Means they have changed the values from the previous, as you all know. Mean pulmonary artery pressure more than 20 mmHg defines the pulmonary hypertension. The precapillary, it is a mean pulmonary artery hypertension of more than 20 with the pulmonary artery wedge pressure of less than 15 and pulmonary vascular resistance of more than 3 Wood units. And for the post capillary, it is a mean pulmonary artery more than 20, pulmonary artery wedge pressure more than 15, and pulmonary vascular resistance less than 3. Okay. They had mentioned a very important table, that is table 13.1, which mentions the limits of the various vascular pressures and the blood flow at rest, like variables like cardiac output, pulmonary artery pressure, their mean, and the limits of. Okay. Chapter number 19, that is innate and adaptive immunity in the lung. They have mentioned the T cells, three subtypes, that is the natural killer cells, gamma delta T cells, and mucosal associated invariant T cell, that is MART cell. And next chapter number 28, a very important change. modern approach to thoracic imaging diagnosis. What they have mentioned here in this type is just you get a patient CT and it shows emphysema and laborious emphysema, that is not that does not suffice. Again, based on that, we have to subcategorize the patient as pre-centrilobular emphysema, mild centrilobular emphysema, moderate and confident. The same for panlobular and paraseptal emphysema. You can see here there is a table given by Freshness Society for CT imaging of the your mainly emphysematous patient. And if suppose you have airway disease, again you have to particularly classify how is the airway disease, and the associated figures like large airway and bronchitis also has to be classified. Details have been mentioned in this table. And in the same chapter, UAP pattern for CT diagnosis of IPF has been added, as you all know, and we have discussed it many times in our previous videos also. Next important thing they have mentioned regarding the follow-up for solid pulmonary nodule, whether it is less than 6 mm, 6 to 8 mm, and more than 8 mm. Both of these follow-up guidelines. And one more next for table 28.4, they have mentioned for subsolid nodules, that is ground glass, part solid, and multiple. Okay. Next important thing they have added uh, how to do lung rat scoring for benign to malignant lesion, that is on LDCT, that low dose CT scan. Okay, suppose the patient has benign thing, you have to give a lung rat score of 2, and suppose the patient has malignancy, you have to give it 5 or 6. This is what is given in this table. It is also in the same chapter. Okay. And one more important thing, he added COVID imaging here in the modern approach to the radiological images. This is regarding all chapter number 28. Chapter number 29, thoracic ultrasonography. They have added regarding three important things. All three important things were regarding the diaphragm. That is diaphragmatic thickening. How do you assess? How do you assess the atrophy? How do you assess the diaphragmatic excursion in the palsy or in the ventration patients? And diaphragmatic thickness and thickening fraction. Chapter number 30, physiological and metabolical assessment of pulmonary disorder. What they have mentioned here, how do you use PET scanning for monitoring the therapy? Suppose you have done PET scanning at the initiation of treatment, again after 6 months or 1 year, you do a PET scan. How do you see the regression of lymph nodes, or whether they are increased, whether the tumor has increased, whether to decide the chemotherapy and radiotherapy? So PET scan is used. That they have mentioned here. And the one more important graph they have mentioned regarding global lung glycolysis and global lung parenchymal glycolysis. This is regarding the bilateral lung. This is regarding the unilateral lung, global lung parenchymal glycosis. Chapter number 32, that is principle and application of cardiopulmonary exercise testing. If full chapter has been changed, you have to completely read it once again because they are written by a new author. Okay. Coming to chapter number 33, that is diagnostic bronchoscopy and transthoracic needle. Use of single non-reusable bronchoscopy has been mentioned, mainly like computer like Ambu, which produce single non-reusable. We do it once bronchoscopy and then dispose it off. They mentioned regarding the robotic bronchoscopy. Robotic bronchoscopy mainly helps in diagnosing the peripheral lesions, combining it with ultra thin bronchoscopy and the navigational bronchoscopy, how to do a biopsy. So we use robotic bronchoscopy system there. And we are getting cryoprobe I have mentioned, and bronchoscopy transparenchymal nodule access. Suppose we have a parenchymal nodule which is not in the according to the airway. So you do puncture the transparenchymal and then you do a biopsy. That is your bronchoscopy transparenchymal nodule access. That is BPPNA. The same thing. They have mentioned a graph regarding the post-test and the pre-test of malignancy. And and in the chapter number 34, that is intervention pulmonology, they have mentioned regarding the medical thoracoscopy, as you all know, for pleurodesis or in diagnosing the peripheral lung lesions or in the pleural malignancies. Chapter number 35, today's last chapter, that is diagnostic thoracic surgery. They have mentioned regarding the robotic assisted thoracoscopy surgery. That is RATS. As you can see, multiple robotic things are used for diagnosing a thoracic lesions. uh, okay, if you have any if you have any doubt, you can slow down the video and then see the important tables. Okay, if you have any doubt, please leave it in the comment box. Thank you all for your patience.